I'm really passionate about. I can see Asha smiling because I think you chaired the when I gave it in the last academy. But this is something that I feel really strongly that we don't do very well, and hopefully this will be a good opportunity to give everybody some ways of applying what they've learnt throughout the academy when you're talking to people in your clinics. So I'd just like to start by acknowledging country and pay respects to the Gimwai Wallaburra Yidinji people, who are the traditional owners of Cairns, where I'm presenting to you from now, and pay my respects to elders past, present and emerging. So what I'm going to talk about today is how we communicate about drug resistance, and is it working? And the spoiler answer to that question is no, I don't think it is. And is there a better way? And most of the talk is actually based on a single, well, it's not really a single journal article, it's a single report that was very sort of comprehensively done, looking at better ways for communicating this sort of information to people. And I'm not going to talk specifically about how we communicate that to people in the Aboriginal and Torres Strait Islander health sector, but it's really what I want you to walk away from today's talk thinking about is how we can use these principles to communicate our work on drug resistance to people better. Because the really important thing about communication is that if you don't communicate well about drug resistance, then number one, you can't influence people's behaviour, and hopefully you will have seen through the academy now that that's really what we're trying to do. We're trying to encourage people to think differently about resistance and to do things differently, and the key sort of intervention for changing people's behaviour is being able to communicate a message to them. And this is really what we're all about. We need to be able to talk to people about the risks that drug resistance poses and explain to them how their actions can improve things. So you may be aware that each year there is what used to be called Antimicrobial Awareness Week and is now called World AMR Awareness Week. It's got renamed this year, and I'll talk to you about how I feel about that in a few slides. It's the week that includes the day of 18th of November, which is World Antimicrobial Resistance Awareness Day. This year, the 18th of November is a Monday, and so the week starts that Monday and then runs through to the Sunday, the 24th. And each year about this time, the WHO sends an email around saying, this is what our theme is going to be. And here's some flashy graphics you can put on your website and some information that you can use. And this year's theme, appropriately enough, is educate, advocate, and act now. And I've just grabbed a couple of the random graphics off their website, which I've listed there for you. Now, I'd be very interested to know if anyone who's not part of the faculty knew that Australia actually has its own website about drug resistance. You can find it at amr.gov.au. And I know Kelly hasn't got any voice today, but number one, has anybody seen the website? And number two, if you haven't seen it and were interested in what the Australian government was doing about drug resistance, how would you have searched for it? No, and look, that's a pretty standard answer. That it's just kind of this website that exists, and if you are extremely online about drug resistance, as I am, and many of us who have been talking to you through this talk have been, you will probably know about it, but it's not something that the average Australian person thinks, oh, well, what's the government doing about AMR? I'm going to go and search for it. So it's really much a website that's written for professionals in the area to show that we're doing something, rather than it necessarily being something that's useful to members of the public. And that's why I'm just asking, the question is the information on it useful? Maybe, maybe not. But it really is the purpose of this page fit for purpose. And I think the primary purpose of the page is so that someone in the Commonwealth Department of Health can say, we have ticked off the deliverable of having a website about AMR. Tick, here it is. If you search on the web, if you search for AMR, I did do these searches again yesterday too, so they are actually still up to date. If you search for AMR in Google, you find out about AMR hair and beauty products and AMR legal. And there is a sponsored link about drug resistance, which is third on the list there, or second on the list, in fact, the impact of AMR on cancer. And if you scroll down that page a little bit, then you get a link to the Australian government website, assuming, of course, you're searching for Australia. And I guess what that's highlighting is that, number one, I personally think that AMR is a terrible term and that most people don't know what it means and what it stands for, and that, in fact, the focus group work that I'll spend most of the talk talking about bears that out. The term that's much more widely known in public circles is superbugs, which, a lot of professionals don't like because it sounds very, casual and sort of comic booky and, like a bug with a, wearing a Superman costume with a cape. But it does have the advantage of having a bit better cut through with the community, who at the end of the day are the people that we're trying to help. And you can see on the right panel there that if you search for superbug in Google, it gives you a useful little blurb, has some practical information, how can I protect myself from infection, but then it also contains a link to the Wikipedia page on antimicrobial resistance. So it gives you some information that's suitable for lay audiences, but also some links to some, I guess, to some more formal, educational material. If you do a search on Google Trends looking for how much people search about drug resistance, it's not very much. And you can see there that the green line for comparison is sepsis. And so you can see that there's relatively lots more searching about sepsis than there is about any of the different terms for drug resistance. And that's actually been increasing over the last couple of years. Excuse me. And regardless of whether you use the term superbug, which you can see has a few little spikes in people searching it around when there were notable news events, really people don't search about drug resistance very much at all. And it's a challenge that we have in drug resistance, that the sepsis people basically have a lot better marketing department than we do. Everybody knows about sepsis. Sepsis kills. It's got nice, punchy, slogans, and it's really gotten a lot more cut through in the media than anything to do with drug resistance have. If you take out sepsis, to actually let you see what's happening down at the bottom of that last graph, you can see that antimicrobial resistance is clearly the least searched for of the three different terms, whether you use superbug, antibiotic resistance, which is the sort of, I guess, kind of the middle ground term. So it's not quite so cash as superbug is, but it's not as sort of cryptic and jargon laden as antimicrobial resistance is. But the trouble is, as soon as you say antibiotic resistance, you'll end up with a microbiologist going, what about resistance in antifungals and antivirals? That's important too. And so we kind of end up with this argument where people want to use the most technically correct term, but it's clearly the one that's least well understood. This is just a reminder, this is from the Commission's aura information, that we talk about antimicrobials as being all of the drugs that we use to treat all of the different sorts of microbes, and that antibiotics theoretically relate specifically to antibacterials. However, antibiotic resistance is certainly a lot more understood by the public than antimicrobial resistance is. Now, going back to the Australian government website, it's actually not a bad website. The web design is pretty good. It looks modern. It works well. It works on all browsers. The information is sort of well laid out and is pretty well structured. And you can see in the right-hand side over here that they've got a practical list that's aimed at the general public, what people can do to reduce their risk of getting drug-resistant infection. So prevent infections by washing your hands and having vaccines, that's good. Prevent foodborne infection by washing your food and cooking your food properly, that's pretty good. Understand that antibiotics only work against bacteria. They don't work for colds and flus, which are viruses. That's also a good and useful message. Although and then it sort of goes on to the next point to say, don't pressure your health professionals for antibiotics if they say you need them. Ask about other ways to relieve your symptoms, and follow your health professionals' advice. And that's all pretty good. However, if you take the text on the government's AMR website and run it through a thing that tells you how easy it is for people to read, and there's sort of complicated ways that people assess this. It's basically to do with word length and sentence length and paragraph length, essentially. So the more big words you use in longer sentences, in dense paragraphs of text, the harder a text is to read. And what it says is that this government information website is very difficult to read, and you probably need to be, in your first or second year of uni, or what the Americans call entry college level, and is that really the best thing for a website that's supposed to be reaching through to the public? It's probably not. You really want a much lower level of readability, something that's more easily understood by people that have poorer health literacy or poorer literacy generally. And certainly the aim for news media or for public information fact sheets or for I guess information campaigns is that you want to be aiming somewhere around a year 10 level. And that's certainly how the website, The Conversation, which many of you might be familiar with, it's a collaborative between journalists and academics for sort of publishing their information, and Asher and some of our colleagues have certainly had an article about drug resistance on The Conversation. And one of the things that they very aggressively do is to try to keep the language simple to improve its accessibility. So we've got this website that, number one, nobody knows exists, that number two, nobody can find very easily because it uses jargon-laden term, and number three, when you do find it, it's very difficult to read, although the information that's in there is actually quite good. You've probably heard about the O'Neill Review a million times already in the previous 10 lectures. This was one of the biggest reviews of the impact of drug resistance, and made a whole heap of recommendations. Very interestingly, Jim O'Neill, the guy who chaired it, was an economist, not a scientist or a microbiologist or a health professional at all. And he, very famously said, "I didn't understand why they asked me to chair this review because I'm an economist and I don't know anything about this sort of stuff." But really, by the time they had finished the review, he was very much on board at what an important problem for health it was, but also what a massive issue for global economy and development it is. It has the same problem that the Australian government website does. If you go to amrreview.org, the landing page has a readability suitable for college graduates, so that's people who have an undergraduate degree. So very, very inaccessible. The report's 85 pages long, which is quite long and it's quite dense. But on my next slide, I'll be showing you the Australian Aura report, which is 350 pages long. And once you get to the content in the O'Neill report, it's very, very jargon heavy. So it talks about AMR, it talks about antimicrobials, and it uses these very very real and very correct, but very alarmist figures, saying that drug resistance will account for the loss of billions of lives by 2050 and will cost something of the order of hundreds of trillions of dollars in direct health costs, indirect health costs, and effect on global development. So it's really focusing on the sort of the big picture. Australia's report is Aura, Antimicrobial Use and Resistance in Australia, which is published by the Commission for Safety and Quality in Healthcare, although this is probably something that the CDC will take on when it happens. Aura is a very complex sort of hybrid of multiple different surveillance programs looking at all sorts of different aspects. So usage of antibiotics in hospitals, quality of that prescribing, how much use gets used in the community. And so what Aura does is it brings all these very disparate data sets together and really provides a very comprehensive overview of both antibiotic use and antibiotic resistance in Australia. However, it's exceptionally complicated. As I said, it's a 300-page PDF that gets released, once every couple of years, once they've finished compiling all the data. You can see an example of one of the graphs there that is very dense. And I reckon there's probably, I don't know, maybe 15 people in Australia who actually read the report from cover to cover, and 5 of those are on the editorial team. Asher's turned her camera off, but I'll ask Asher if you've ever sat down and read in detail an Aura report in cover to cover, not just stolen graphs from it for the purpose. No,
definitely not. It's the stealing of graphs. You're right, that we kind of look for the data to support the little small niche thing that we're talking about that day.
Yep, absolutely. Now, having said that, they do provide some very good community like they have like a single page infographic for about 5 or 6 different things. And so, do go to their website and check it out, because they do make an effort to communicate some of the important findings in an accessible way. But the report itself is like, it's for bigger bug nerds than me, and that's like setting the bar pretty high. Now, what we're going to spend the rest of the talk talking about is this bit of research by the Wellcome Trust in the UK. So the Wellcome is a charitable foundation that addresses lots of different issues in health, and one of their priority areas is to do with drug resistance. And what they did is they ran some focus groups, initially just in the UK, but then later on in the US and in various parts of the developing world as well. And they asked a whole heap of questions about lots of different aspects of drug resistance. You can see the graph there. It was whether people were aware of these terms, and are you familiar with the term, and do you have a vague idea of what it means, to the level where you could kind of explain it to me. And so oh no, sorry, this is the number of articles using those words. And so you can see lots of articles about superbugs. Orange bars are the UK and green bars are the US. About the same about antibiotic resistance, about half as many about antimicrobial resistance, slightly fewer about drug-resistant infections, a good number on antibiotic-resistant bacteria, which seems to be disproportionately more common in the States, and basically almost no articles about AMR. So when they went and did these focus groups, they said, what does the term AMR mean? Nobody knew. And if we said, well, what if I told you that it means antimicrobial resistance? What does that mean? That was a little better because it had the word resistance in it, but it was still not very good. The awareness of antibiotic resistance was better. And if, as I said before, if you use the term superbug, then that was better still. But there's a deep reluctance from professionals to use superbug because it sounds a bit casual. One of the other things that they found is that the way that the O'Neill report presents its results, that billions of dollars it's billions of lives and trillions of dollars. It just doesn't work. Those sort of numbers just turn people off. They go, that's an unimaginably large amount of money that I can't even think of. And I've never even heard of this problem. It can't possibly be that bad. The doctors just must be making it up because they want research funding. And they're actual direct comments from the Reframing Resistance report. So what Wellcome did is they expanded the focus groups beyond the UK and US. As I said, they went into the developing world as well, in different parts of Europe. So they got a sort of a spectrum, not as broad a spectrum as we would like, but people from non-English speaking countries, as I said, people from India and Thailand and Kenya. So there was an effort to make it sort of somewhat inclusive. And what they really wanted to do was distill this down into a report about how to communicate about drug resistance effectively and to use this as a tool to promote understanding and motivate action. Now, I guess I'll highlight this by saying this is quite an old report. I think it came out in 2016, and I'm still having to give a talk about the fact that we don't do it very well. So why do we need it? Well, coordinated action on drug resistance is happening much too slowly. If you ask politicians about drug resistance, this is certainly better than it was 5 years ago. They say, oh, yes, this is important, but, compared to all of the other government priorities, and particularly over the last few years compared to COVID, it's not a high priority. And we know that the way to get politicians to do things is to have lots of their constituents ringing them and emailing them and pitching up at their electoral offices saying, hey, why aren't you doing something about these drug resistance problems? And so we're in this sort of cycle where, because public awareness is so poor, there's no pressure on the politicians. So the politicians go, oh, the eggheads tell us that this is kind of important, but it can't be that important because we haven't got people bashing down our door about it. So, we'll do all this other stuff and prioritize it. Now, what's the problem with the way we communicate? So we have lots and lots of terms. There's AMR, there's drug-resistant infection, there's superbugs. I've already touched on the issues about the use of the term antimicrobial versus antibiotic. There's multiple ways that this is framed. You hear people talk about the war on superbugs, which is bad for all sorts of different reasons. People talk about economy or more, how it affects the hospital system, and the coverage that makes it through to the media is very disjointed and tends to be focused more on outbreaks rather than sort of the global issue of drug resistance. And if you hang out on social media and look for stuff about drug resistance, it's about like 50 people tweeting at each other, or when Twitter was not just full of Nazis and crazy people, it was 50 people tweeting at each other about drug resistance and everyone else completely ignoring them. And this is the the graph looking at sort of what proportion of people had heard of different aspects of sort of the drug resistance. So, only 10% about overprescription of antibiotics, 10% about super gonorrhea, and, much, much lower rates of, specific problems.
I definitely like surfing an E. coli at the bottom of the list, Trent.
Yes, it's great, isn't it? Surfing an E. coli and house mice spread superbugs. That was another cool one, I thought. Now, I'm aware I've already been talking for a while, so I'm going to start scooting through this a little bit. These are the 5 principles of reframing resistance. I won't linger on this slide because I've got a slide on each of them coming up. But essentially what we need to make people understand is that drug resistance is not something that is only a problem if you're a bug nerd. It's a big problem for the health system. Sure, there's not as much of it around as sort of the major medical conditions like heart disease and stroke, but people don't understand that if the more resistance you have, the more difficult it becomes to fix all those other things. Chemotherapy for cancer, intensive care, joint replacement surgery, lots of other different sorts of surgery, like surgery for bowel cancer or, having your appendix removed. All of these interventions are critically dependent on antibiotics. And if the antibiotics don't work, you can't do them, or you can do them, but they're much less safe. And so what you need to do is you need to provide stories that are relevant to the people who you're listening. So you don't say, drug resistance is bad because it means it will affect our ability to do joint replacements. You need to say to people, hey, your Aunt Betty who had terrible arthritis and then could climb the stairs to get to her front door once she had a knee replacement. If drug resistance gets much worse, we won't be able to do that. She won't be able to have a knee replacement. Or if she does have a knee replacement, she might get an infection and then they need to chop off her leg. And that seems dramatic, but making it a personal story is much more relevant than just going, it'll affect the health system and cost billions of dollars. And when they do message testing, they specifically looked at, what extent does this statement make you feel that antibiotic resistance is a priority issue? And so you can see that talking about trade and tourism and poverty and financial crisis are sort of way over on the sort of the least influential side. If you just say it's a major problem, then that's like flipping a coin. But if you move sort of, the numbers are small, it's between 36 and 60%. But you need to let people know that it's a problem that we can solve. And that it will, that the scale of the crisis is important and that it affects the healthcare that we're able to provide. We need to explain things succinctly because the baseline level of knowledge in the community is very poor. Most people who talk about drug resistance, even when they come to my clinic, still think, I've become resistant to that antibiotic, that they think that resistance is a quality of the person rather than of the bacteria. And so we need to stress that resistance comes from the use of antibiotics. People say, but I don't take antibiotics very often. I only take them when I need them or when my GP gives them to me or once or twice a year. So I'm probably not going to be affected by this problem. And therefore, drug resistance is not a problem that's going to affect a person who's like me. And the message needs to be simple. The preferred term is actually talking about bacteria because most resistance occurs in bacteria, most clinically significant resistance. Germs sounds too casual and nobody knows what microbes are. And you can see some of the quotes from the focus group there. I don't understand the word microbial, or microbial sounds like microbiotic. I don't know what it means. So use less technical terms, which is why I particularly object to the use of AMR to describe what we do. The other thing that we suffer from in drug resistance is that we don't have an umbrella term. So everybody who's talking about climate change now talks about climate change, or the civil rights movement, or passive smoking. All of these issues sort of coalesced under a single term. Whereas I've listed 6 different ways that we can describe talking about drug resistance there. And it's really important to avoid the use of the term, particularly AMR, but especially antimicrobials more generally, unless you're communicating with peers. And the Wellcome's preferred term was drug-resistant infection, because that's more easily understood. It says what the problem is. So drug resistance has an analogy that it's already how we describe TB. So there's multi-drug resistant TB or extensively drug resistant TB, which is nice. Drug resistance covers those pedantic people who go, but what about antifungals? By including drug covers antifungals and antibacterials and antivirals, so that's nice. And it has the problem in the catchphrase, so drug-resistant infection. And then people say, oh, but what about the fact that not everybody who has resistance has an infection? It might just be living, but you could argue about these things forever. But hopefully you will notice that I've intentionally said drug-resistant infection for most of the time through the talk, except when I'm specifically referencing, antimicrobial resistance awareness week. The third principle of communication is to I guess encourage people to believe that it's not a problem that's not going to affect people like them. It's a universal threat. But this is a fine balance. You can't just say, well, this is a risk to everybody, because they go, oh, well, they would say that it's, that's what they talk about. So you need to increase the likelihood that people will think it will affect them. And so you need to use things that are common and relatable. So do you ever remember, having a bad dental infection? Well, if that was bad enough that it went into your bloodstream, if you lived in the wrong part of the world where there's lots of drug resistance, that might kill you. Or urinary tract infections. That's a very relatable problem, particularly for women, because about 30 or 40% of women will have at least one urinary tract infection in their life. It occurs now in Australia that we have people who get urinary tract infections that can't be treated with tablets. People need to come to hospital and be put on intravenous antibiotics at home to treat their urinary tract infections because we don't have tablets that are effective. And that's a message that I think that's not as well known as it should be, and is a very simple message that will, I guess, make people see, or make people more likely to see, that it can in fact affect them. And we also need to focus on the here and now, not the O'Neill report sort of, billions of dollars by 2050. What we know is that being apocalyptic is great for catching people's attention. Oh, dark ages, pre-antibiotic era, we're not going to be able to do surgery anymore. Everyone goes, oh, right, okay, that sounds really important. But then it's very bad at motivating them to change their behavior because of that. Oh, but that's not going to affect people like me. Like I don't have cancer, so I don't need chemotherapy. So, I'm sure the smart infection doctors will do something to work about it. As I said, post-antibiotic era and back to the dark ages actually reduces credibility of your message. It's seen as being over-sensationalist and clickbaity. And if you talk to people about trillions of dollars, they don't care because, number one, it's an unimaginably large amount of money. And number two, well, what even is $1 trillion? Who knows? And so you need to be specific and say that drug resistance is harming us now. It's stopping our ability to provide healthcare, and it's going to get worse if we don't do anything about it. And the final principle is that we need to frame the problem as having a solution. If you say drug resistance is important and it's stopping our ability to deliver healthcare, then that has some effect. But if you follow that on with, but if we do something about it now, like using fewer antibiotics, we can improve things, that actually improves the resonance of the message by up to 10%, which is, is a big change in this sort of communications literature. Your examples need to be specific, not we need to do something, but we need to not take antibiotics when we have a cold or a flu because they're caused by a virus. So your message needs to be simple, but specific. It's kind of like the SMART goals that you've heard about. If you do a management role, it has to be, something that you can measure, something that you can do, something that has a definite outcome. And so we want to communicate not a sense of doom and gloom, but a sense of optimism if we work together. You can help us solve this catastrophic problem by doing these things. And that gives the people some agency about about taking control of their health, which is an important principle of what we do with health promotion. So where do we go? Well, you need to be the change that we want to see, and so that means not getting antibiotics for your colds and flus, but also positively communicating the message to people in our health service and to our patients and to our families. We need to advocate for action in your communities. And the thing that I'm not going to cover today in the interest of time, but that we really need to think about, and that I think from the Academy faculty point of view that we think is an important sort of two-way dialogue that we need to have with you, is how are we going to communicate this message to your patients? How are you going to talk in your communities to your patients about this in a way that you think that they're not only going to understand, but is going to result in positive behaviour change. Now, I will leave this as an exercise to the reader. This is the first few paragraphs off the Australian Government website. Again, you can see that you need to be a university graduate to be able to accurately and sort of easily interpret what this means. So, I've given Claire a copy of my slides, and I'm very happy for you to download them and sit there and have a think about how you might want to translate that message into something that your patients are not only going to understand, but are going to take on board and do something with. So have a think about what you're going to say to your patients in your clinic. And the summary is that the drug resistance is undermining our ability to provide medical care now by causing urinary tract infections that can't be treated, by making it more likely that people who have hip or knee replacements will get infections and need to have their surgery done again. That drug resistance relates to antibiotic use, and we can all do something by taking fewer antibiotics, and when we do need to take them, making sure we take them as directed. That we need to talk about how drug resistance is a problem that affects everybody. That includes me, it includes you, it includes Aunt Betty and her knee replacement, and it includes your next door neighbour who had to go into hospital for something the other day. And although we need to be aware of what's happening in 2050 and all the terrible things, we also need to focus on what's happening right now, because it is actually an important problem, and that we encourage action, not just in a very general sense, we need to reduce resistance or we need to use fewer antibiotics. We need to give specific examples so you can help by not asking your GP for antibiotics when you have a cold. And that is all I had. So I'll stop sharing and happy to take some questions before I have to run off to clinic.
I think, Trent, there's been